So good afternoon, everyone, and welcome today to our session on endometriosis. This session today is on the occasion of the Endometriosis Awareness Week, and we are naming the session Ask the Experts, as we have two eminent experts with us joining us today on a Sunday, and we are very grateful that they have given us their time to be able to interact with our patient group. Women with Wings is a patient group that brings together women who have been diagnosed with endometriosis and are managing their life with this condition. It is meant to provide a platform so that the women can share their experiences with each other and ask questions with each other and stand in solidarity, as many of them go through a lot of hardship, especially severe pain and the associated lifestyle changes along with it. So we have a very active group with a lot of women asking questions, sharing answers, also providing advice. We also have nutritionists, we have people who give counseling, and overall it has been a very enriching experience. But we felt that this needs to go a step further, and people, because there are a lot of myths and misconceptions around endometriosis per se, and more myths and conceptions around the infertility issues, we felt that it is best to hear from the experts and learn from their experience as to how to manage this whole issue. Statistics say that 30% of women who are diagnosed with endometriosis might have infertility. And considering that in the socio-economic context of our country, infertility has a lot of taboos around it and a lot of stigma around it, people find it difficult to share. And this leads to even more stress within the families and within the couples. And if the woman is alone, then with the woman herself. So how do you manage this condition? What is it that you need to know to be able to take the right choices? And how do you manage this condition after you have been given the right kind of opinions and expertise around it? So without much ado, Ankit, if I can have the next slide, please. So this is me. We can skip this. I run an organization called Dakshama Health, which is a not-for-profit organization, and we have a lot of work with many patient groups, and endometriosis patient group is one such patient group. We also work with a lot of other non-communicable diseases like cancer, diabetes, both type 2 and type 1, COPD patients, dermatology, chronic diseases like psoriasis, autoimmune conditions like multiple sclerosis. So there's a whole wide range of patient groups that we work with, but today's topic will be focused on endometriosis. If I can have the next slide, please. Our first expert today, and we are very fortunate to have with us Professor Narendra Malhotra. He has a whole series of degrees, so I will not go through that. He is the Managing Director of Global Rainbow Healthcare, and he resides in this beautiful city of Agra. Very close to the Taj Mahal. I saw that in his background last time. He's a director at ART Rainbow IVF Manyata CSE Project Positive Health Rotary District 3110. And he has a whole lot of other activities to his credit. He is a professor in Sarajevo School of Science and Technology, Croatia, also a professor at Dubrovnik International University, Croatia. He is the past president of many associations and the member of FIGO Guidelines Committee between 2014-2017. He is the advisor to the IVF unit Maulana Azad Medical College. Over 125 papers and chapters to his credit, as publications, many papers and guest lectures, and a lot of awards as well. So our next speaker, if I can have the next slide, please, is Dr. Renu Sehgal, and she has a fellowship in advanced gynecological endoscopy and is the chief of Department of Obstetrics and Gynecology and coordinator of operations at the Artemis and Daffodils Hospital, Gurgaon. So today, what we will do is invite Dr. Malhotra for his first session, and he will explain the medical and technical aspects of infertility and lead us through a small presentation. And following him will be Dr. Sehgal, who will help us understand the psychosocial aspects, the stigma, and how the family deals with the whole issue of infertility and what kind of advice patients need to be able to manage the condition. Over to you, sir, Dr. Malhotra.
So very good evening to all of you. It's indeed a pleasure to be here on this endometriosis awareness group. And last 1 month, I've been addressing endometriosis on various forums. And we do pledge, that's me and my wife, Dr. Jaideep from Agra, and of course our daughter. We do pledge to add joys to her life by tackling endometriosis, especially the infertility part of endometriosis. So women have to be given wings. And in Foxy in 2018, the logo was Pank or Parvaz do, Nari ko Akash do. Vajud nahi Vishwas do, Taro bara Akash do. So give her wings and let her soar. And these wings, some diseases of women, her unspoken problems, diseases like endometriosis have cut these rings. This is a lovely painting by Jody, which you can download from the website on endometriosis awareness through art association. And it just shows the pain of this woman. And it just says that this is one of the most challenging and elusive diseases we have met. Now, when we look at some statistics in England, India is even worse. So 20% of people have never heard about endometriosis. It takes 7.5 years to diagnose. 1 out of 10 women are suffering, cannot have babies. 176 million worldwide are endometriosis. 32% suffer from depression. 56% of these women go only to the GPs, and only 1/3 of them feel that their current pain treatment is effective. And 80% of these women miss work due to the pain of endometriosis and the infertility part. So that is the wings which we need to give these women back. What is endometriosis? Well, a woman in simple language has menstruation, that blood comes out of the cervix, but some blood goes back into the abdomen through the tubes. And this endometriotic tissue grows in places outside the uterus. And then it starts growing with the hormones of the woman, the estrogen, and it forms implants, adhesions, pain, endometriomas. So it is kind of a benign cancer. It is a growth which occurs like cancer, but it is not cancer. And March, we all know, is Endometriosis Awareness Month. The first week was celebrated as the Endometriosis Week. And today we are going to talk to you all about endometriosis and infertility. 1 in 10 women will have endometriosis. How do we break the cycle? Cycle of dysmenorrhea, that is pain during periods, tiredness always, infertility, painful intercourse, pain. That is what our aim is, to break this cycle of endometriosis. When we look at worldwide, the 4 common problems these women have is pain during periods, pain during sex, infertility, which we're going to concentrate today, and chronic pelvic pain. Hardam pain bana rehta hai. And it is seen almost in 20% of Asian women. And 5 to 20% women will have this disease without showing symptoms, which is worse. 15 to 45 have present with pain, and 20 to almost 50. We just heard Dr. Ratna say 30%. It's some places as high as 50% of those who cannot get pregnant have endometriosis, and 25% have pain. And disease does not finish with periods. Perimenopausal, when the menopause is about to come, it still can be there in these women. And again, this woman has to undergo all these cycles. So every kind of woman it affects. Of course, there are some characteristics. People say it is like a benign cancer. How do you treat such a thing? Because when you say it is like a benign cancer hota hai to surgery karke nikal diya, medicine de diya, things like that. So it is an enigma. And this woman put a post in our Instagram. I never know how I will feel tomorrow from today. How will I feel with the pain? So historically, a lot of investment has gone into research, but still we have not found the causes, the treatments are the correct, and it will affect the quality of life. So girls who are getting endometriosis, if we don't treat them at the time, it will affect their future fertility. Now let us look at the diagnostic delay. When this girl comes as gets pain in abdomen, misses school, or pain in periods, the first thing she goes is to a general practitioner. And the general practitioner usually says, it is period pain, ये तो सबको होता है, लड़कियों को होता है, don't worry. And 1 year goes till they take her to a gynec. And then the gynec again says the same thing. These are girls, they will get this. They don't get investigated, and they are usually given some painkillers during, and that's it. Then finally, another 6 years go by when they finally land up with an expert who diagnoses these girls with endometriosis. So there is an average delay of 7 to 7.5 years till you make a final diagnosis of it. This is terrible for a disease which is so common. And despite of so many guidelines, and especially the latest 2022 February, just last month, we have the latest ESHRE guidelines on what treatment to use. Now, it is not one doctor disease. So the gynecologist, of course, is the head of the team, but the surgical team, the pain specialists, the psychotherapists, the counselors, the nurses, the psychologists, the nutritionists, patient support organizations like PAIR, non-traditional practitioners like acupuncture, acupressure, all have a role to play. The main thing is, which we are worried is in the red, which you desire for pregnancy or infertility or subfertility. So endometriosis causes infertility in 25 to 40%, up to 50%. And the rest is pain, sexual intercourse, abdominal pain, all that. Now, effective medical treatment is very effective in getting the pain relief, but medical treatment will not work for infertility because it suppresses the disease, and so it suppresses ovulation. So while it will control the pain, but will also suppress ovulation and will not cause, or the pregnancy will not occur. So it is $1 million question whether these women should be given medical suppression or whether we should straight away try to get them pregnant. So because if you give them medical suppressions like oral contraceptive pills, like Endogest, like GnRH agonist injections, monthly, 3 monthly, all that will suppress ovulation and not cause fertility. So that debate is what the expert has to answer. So let us see what the recent, these are the 2022 ESHRE guidelines. What do they say? The treatment of endometriosis associated with infertility. So these women should go for early assisted reproduction, non-medical management for infertility. And if they are young girls with severe endometriosis, fertility preservation should be advised, oocyte freezing, and when or later they get married in later age, then those can be used. Otherwise, the ovary will get damaged and there'll be no oocytes. And they should also be told that in pregnancy, first we used to say, endometriosis, get pregnant and disease will vanish. Now it is shown that in pregnancy, because of some progesterone receptors, this disease can actually aggravate also. So treatment associated with endometriosis is that do not suppress, very strongly recommended. And sole purpose is to that we should get the pregnancy, strongly recommended by ESHRE. And the clinician should not prescribe anti-inflammatory, all the other drugs which suppress ovulation, but they should try to get the woman pregnant. And laparoscopy should be offered early to these women because to correct the pelvic endometriosis, adhesions, and restore the factors. Of course, if they are endometriomas, big cysts like this, then they should be charted on the EFI, the endometriosis fertility index, and their chances for getting pregnant after surgery should be discussed, and whether they'll need IVF, ART or not should be discussed. So medically assisted reproduction, if it is stage 1 and 2, IUI immediately with ovarian stimulation. Stage 3 and 4, correct the anatomy by laparoscopy and take them up for IVF as soon as possible, because that would be the strong recommendation according to the ESHRE guidelines with it. And if they are young girls, 16, 17 with big ovarian cyst, then it is strongly recommended that their oocyte should be frozen and fertility preservation, because surgery will destroy their ovaries and they later on they might not have oocytes left. Then of course they should be told about pregnancy, which I told you that in pregnancy the disease can aggravate. So infertility comes, hormonal treatment not recommended, surgery recommended, medically assisted reproduction recommended, early recommendation. Endometriosis in pregnancy can increase. So medical treatment with GnRH agonist is given, followed by IVF, and not just used for suppression. Pentoxifylline, anti-inflammatories, or will reduce the pain, but will not treat her infertility. So reduce the pain and then try to get her pregnant. Ovulation suppression, not to be done. Surgical intervention, if they have big cysts like this, so these, and only aspiration is not the treatment. Now this is only aspiration. If you leave it, it will fill up very soon. So cystectomy has to be done. If it is very big cyst, we need to de-roof the cyst sometimes and then. Now, if it is only adhesions, flimsy adhesions, these cannot be diagnosed by ultrasound. So you need to do laparoscopy if they're not getting pregnant and do endocytosis and correct that. And here also we will evert the ovary and do a cystectomy or a complete. So endometriosis surgery should be done by an above average laparoscopic surgeon, not an average laparoscopic surgeon, or an expert laparoscopic surgeon should be handling it. You have to go to the best if you have endometriosis, because a half done incomplete surgery will lead to more problem. So before IVF, whether we should remove the endometrium or not, that will depend on your doctor. If it is big, then we do recommend it. So pre and post surgery, sometimes medical treatment is given, and then early IVF. What about additional treatment, back massage, acupressure, acupunctures? All these give a lot of psychological relief, pain relief. And it is said that they improve the blood flow to ovaries, but there's no very strong evidence to say that this will work for pregnancy. What works, and we have to chart into this revised AFS classification or endometriosis fertility index, and then give the patient the right chance of what treatment will work. Then, of course, our duty as expert is to make the general practitioners aware, because the general practitioner has to be aware this is a disease which they should catch very first. And we have to tell them all women will have retrograde menstruation, not all endometriosis, because which are not well understood. So age has to be told, women between 25 to 34, most likely. Genetic predisposition, if the mother is suffering, the daughter can suffer from endometriosis. Lifestyle, if the woman's lifestyle is very hectic, very high-strung women, very achiever type of women, they will more likely to get endometriosis. Those women who work in the night, circadian rhythm, night shift workers show more endometriosis. Toxins in the diet and in the atmosphere will damage the reproductive, immune, and endocrine system. So that has to be look after. Dioxins in patient serum levels can be studied, and they can be told you're living in a toxic environment. People near them smoking, recreational drugs, colors in the food, artificial colors, etc. So, ladies and gentlemen, it is difficult to understand cancer. It is more difficult to understand a benign cancer, and is impossible to understand epiphenomenon. And that is what endometriosis. And Sir William Osler said, he who knows endometriosis will know the whole of gynecology and will understand the woman much better. So, but it still remains an enigma. That is why we are doing these awareness weeks, and the yellow ribbon is what we try to do. I thank you very much. Welcome you to this March Endometriosis Awareness Month. And I bring you greetings from my city of Taj, where I practice as an obstetrician gynecology, the fourth generation OBGYNs in our family, and all me, my wife, my daughter, and my son, all are gynecologists. My father, mother, and my grandfather was also. So thank you very much for inviting me here to share some of my views about endometriosis and infertility. Thank you, Dr. Ratna.
Thank you, sir. And your presentation actually raised a lot of questions in my mind as well, because as you said, this is an extremely difficult condition to treat. And, socially and culturally, IVF and ART have a lot of stigma attached around it. And most people would not want to go for that unless there is no other option available. Also, when we interact with our patients, we hear a lot that, they have been advised to become pregnant, and probably the patients do not understand why this advice has been given. So many are, offended that this is the pathway that has been suggested to them, especially if they are career-oriented women and are not planning for a marriage or for getting into a relationship. So getting pregnant is out of the question. So I was wondering if Dr. Renu, you could take up the topic on why it is so important to preserve your ovaries, especially if you are young, and how do you manage the stigma attached around ART and IVF and the other means of getting, a child if you are not able to conceive in a biological way or in a natural way? Dr. Renu?
Dr. Ratna, just give me a moment. I'm just trying to open my presentation.
No problem. So while Dr. Renu opens her presentation, maybe I could ask one question of you, sir. Why is this confusion about, most people, at least from the patient's perspective, I think the most important thing for them to manage is their cycles and the pain. From what I heard from you, if you're actually managing the pain, then it is suppressing the ovulation and is not in the best interest of the women. So this seems to be a dichotomy. And how would one woman make a choice between these two if she actually wants to plan a family?
So that is exactly why it is an epiphenomena, enigma, whatever. So the first thing which we try for the pain is to give them NSAIDs, painkillers, simple painkillers during the periods or during the full month, and tell them for lifestyle management, yoga, exercise, fresh air, walking, back massages, things like that. Try to get them off the pain and try to ask them to change their lifestyle into a more favorable lifestyle. Now the pain may get relieved for 6 months, it may get relieved. But then if it doesn't, then you have to put them on oral contraceptive pills. The minute you put them on pills, they cannot get pregnant. So in the 6 months with painkillers, you try to ask them to get pregnant if everything is all right. If they don't have a cyst, if they don't have adhesions, husband is all right, tubal factor is not there of infertility. If they get pregnant, fine. If they don't, then we have to put in a laparoscope, correct whatever adhesions, and start her on ovulation induction and IUI as soon as possible. So medically assisted reproduction is to be, and there is no stigma to it. You can proudly say, I have an IVF baby. You are special because you have an IVF baby.
Thank you, sir. So I can see that ma'am is ready. So ma'am, over to you.
Yeah, thank you. Sorry for the glitch.
No problem, ma'am.
Okay. So I think Dr. Malhotra has already said, sir has already touched all the aspects of infertility and the medical part. And what I am going to talk today and what I love to talk is like counseling of the patients. And there are challenges of endometriosis that are beyond the medical management, that we don't have to focus them only as doctors. And those are the ones that I want to talk about. So what I want to emphasize is that menstrual health is just not a women issue. It is an issue of gender equality, and it's an issue of social justice. And there is a huge deafening silence surrounding invisible issues, which have both emotional and economic implications for millions of people around the world. And one of them is endometriosis, of course. So if we take the facts and figures of endometriosis, we see that, like sir said, that there are so many millions of cases, and those millions of cases, there isn't enough research, and of course, there is no absolute cure. And average diagnosis time is 8 years, which is wholly unacceptable. And we have to know that the stigma and shame around discussing one's periods or menstruation, we have been brought up, especially in Indian scenario, we have been brought up to, get ashamed of saying something about periods. We are taught to, get our pads from the grocer in a black bag and hide them somewhere. So period is a big taboo subject. So the shame and stigma around this discussing is that women often remain silent throughout the pain rather than asking questions and seeking any medical help. We have now had a huge data and about 22 publications as to the study related that 62% of the women between the age group of 16 to 54 will not go to a doctor, and it is exaggeratingly high, 80% in 16 to 24 years old. They don't go to a medical practitioner when they unless and until they have excruciating pain. And 47% of the female population aged 16 to 54 and 57% again of 16 to 34 years olds would be concerned to tell their employer for a leave if they have pain during periods, if they're not able to cope, because they have a huge stigma associated that they would be labeled as not being able to work, they are not good employees, they are not sincere in their work, and they are ashamed to talk about it. And yes, of course, like sir said, 50% will have infertility. So there is a huge negative impact on our quality of life. And the main challenges will be, of course, deterioration of physical well-being, which we all know, pain everywhere, pain, chronic pelvic pain, pain during periods, pain during intercourse, pain while defecating, pain while urinating. I mean, that pain is so much that it's part of me. That's what people come and say. Like, I cannot imagine myself without that pain. A great challenge is the psychological dysfunction. Psychologically, they become depressed because, like sir said, you don't know what to expect the next day. It's going to be the same or something different. Then their daily life activities are affected. Their work productivity is affected. If they are like young girls in the age group of 16 to 24, they can miss school, they miss deadlines of projects, they miss their assignments, they miss their exams. It really affects their grades. And when they are employed, when it does affect their promotions, their career choices, what they will seek to do. It has a huge impact. Now again, there is a huge impact in the social participation. You are not able to join everybody when you may have pain. There may be social functions, there may be rituals, there may be somewhere that you need to attend to. You are afraid to go on holidays because you may feel pain. You may not enjoy a holiday, even you may not enjoy a honeymoon because the sexual dysfunction is so much. So these kind of effects. Then quality of sexual life is really bad. One, you have a bad sexual life, and two, you have infertility. You do not want to have sex because you have pain, and your partner thinks that you're shooing him away, and on top of it you have infertility. Then the infertility becomes your problem, you're doing. And there is a huge increased financial burden which you have to incur. This I found in a BMC journal, a huge graph which depicted it very well, that insufficient coping with endometriosis is usually because of lack of information and an uncertainty which is there because of the disease. And the contradictions and the misbeliefs, the myths, the taboos, everything increases this insufficient coping. While as if you are active and emotion focused coping, it is because you have obtained information, you have partnership, you have family support, you have healthcare providers who have diagnosed your endometriosis on time, you have read, you have gained information through internet, you've talked to fellow patients, you have reliable information by support groups. And this helps you greatly in coping with the endometriosis. So what are the small tips of coping with endometriosis? How do you prepare self and family to cope with it? Diet. Certain types of diet have been told that avoiding them may reduce the inflammation and pain due to endometriosis. So adjust your diet. Eat fresh fruits, vegetables, whole grains, nuts, seeds, salmon, sardines, fish do help. Avoid dairy, beans, onions, red meat, caffeine, alcohol. a 2021 trusted source study said that 6.4 out of 10 effectiveness score can be given if you do just dietary modification for reducing the pain due to endometriosis. In 2020, a review of 15 studies found that 68% of women reported that there is mild to high stress with endometriosis. And it is a very, very important to find ways to reduce it. So get into exercising, do yoga, go for a walk, engage in a hobby that you enjoy, that puts your mind to something positive. Read a book, listen to music, take warm baths. Trying medication, breathing techniques, aromatherapy also helps sometimes. People with endometriosis often have poor sleep quality, and this can be due to, of course, their physiological symptoms, the physical symptoms that they have, and also related to the stress managing endometriosis, or both together. So stay rested, keep your bedroom dark, quiet, comfortable temperature, set bedtimes and wake up times and stick to them. Reduce the use of electronics close to bedtime. Focus on instead on relaxing activities like reading a book or taking a warm bath. Limit nap times during day, get regular exercise, avoid caffeine and alcohol, and consider a melatonin supplement or an anxiolytic. Be active, aim at about 30 minutes of exercise most of the week. Ask a healthcare professional about the exercise routine that is most appropriate for you. This improves your cardiovascular health and maintains healthy muscles and bone, but it also reduces your pain. It manages your weight, boosts your energy levels, lifts your mood, and helps you sleep better. And all these will have impact in your fertility if you continue. Most important, seek a support. While endometriosis can be isolating, you have to remember that you are not alone. Tell your loved ones as well as your colleagues what you're thinking, what you're feeling, how best they can support you. Direct them to websites and resources wherein they can learn more about endometriosis, which may be useful for their understanding of you. They want to help. Remember, your family wants to help, your partner wants to help, your friends want to help, only they don't know what you're suffering from. And also for you, learn as much as you can about endometriosis, different strategies of treatment. You learn about the recent breakthroughs, if there are any, and talk with a mental professional. Don't take it as a taboo. This is a big taboo in India. Because you have to work through your feelings. You have to get past your emotions. You have to address the symptoms of anxiety and depression, and join a support group where you can meet a person online. How do you deal with pain and infertility? Of course, pain management, we all know, hot water bottles, TENS machines have now come in, which are very good for pain relief. Some herbal teas have anecdotal impact, but prescription pills are usually the ones that we give, and acupuncture may do help in relieving the pain. How do you cope with the infertility? Remember that you are not alone. Just remember this. Endometriosis affects 1 in 10 women. So out of 10, 1 is you. And half of these women are like you, struggling to get or to stay pregnant. Allow yourself to feel. There may be strong and overwhelming emotions. You may be guilty, you may feel shame, you may feel inadequate. Some people say that मुझे लगता नहीं कि मैं एक औरत हूँ, मुझे अगर मैं माँ बनने की capacity नहीं है तो I have doubts about my womanhood. No, these are not wrong notions. These are just emotions. You may feel jealous of other people who have children. You may have anger. Why me? You may have fear of the unknown. Like, if I have endometriosis tomorrow, maybe kal bacha nahi hoga. Stress, and among other things. While coping with infertility is okay, it is also okay to feel anxious and sad and stressed, but it's more important to deal with it heads on. Information is your friend. The more you know, the more empowered you are. And you have to develop an action plan. Keep an ongoing list of questions for your doctors. Explore and consider your options as soon as possible after the diagnosis. Like Sir said, that if you're young and you feel a bad endometriosis, it is a viable option to think about egg freezing, because you may not get enough eggs later on. Think, when should you get pregnant? You may not be able to defer your pregnancy till you are well settled and want to do, if there is endometriosis, you may have to, sometimes, get you pregnant early on. But if you're not, then egg freezing is an option you should consider. Diagnosis, knowing that you are taking positive steps forward, will probably make you feel more in control of your future. You should know what to do when. That is what is empowerment. And most important, build your support network. Don't be afraid to ask for support of a mental health, of an infertility counselor. Grow your support network in the form of support groups. Support is a great way to meet and talk with individuals who have been in same situation. Some of the stories of others in your support group may provide you with hope. They may answer your questions. They may calm your fears, and you may also make you feel that you are not alone. And especially this is for Indian scenario, some individuals may find it helpful if they let the close family members or friends in their infertility struggles. Well, you have to weigh those options, because it may go both ways. You may, sometimes you may get jeers and, slide marks, but mostly, let me tell you, whenever you have problems with infertility, a close family and group, especially then the family group that we have in India, the parents, brothers, siblings, sisters, they are a great support. And important is to get rid of the myths, taboos, and the stigmas. Like myths like teenagers are too young to get endometriosis. Pregnancy is a cure for endometriosis, like Dr. Malhotra just said. If you have endometriosis, you can't have a baby. Not all people with endometriosis are infertile, mind you. The pain you have, the more pain you have, the more endometriosis you have. No, some people with severe endometriosis may just be pain-free. And period pain is normal. Stop normalizing the period pain. It is not a part of being woman. Hormone treatments are a cure for endometriosis. No, they are not a cure. They are just a suppression method for endometriosis. And oh, weird, the endometriosis is a sexually transmitted disease. No, it is not. We have to get rid of sexist attitudes, beliefs that women's pain is normal during menstruation, and the women who complain about discomfort during sex and their periods are hypochondriacs or hysterics. Endometriosis is perceived by general public as less serious than other chronic medical conditions, like maybe psoriasis, maybe diabetes. No, it is not. It is actually lasts you a lifetime, and you have to have coping mechanisms to deal with it. And also, sometimes you have a portrayal on the media that reinforces a false notion. They're trying to help, but they'll say, don't let your periods prevent you from doing anything. No, how does an endometriosis woman take it? She is criticized and ostracized by the family members, sexual partners, and employers. Oh, you have period pain. Every time you have a period pain, you are sitting at home and not doing anything. Oh, now it is your bahana of getting the chutti. Employers accuse them of malingering. They question their legitimacy of their symptoms and issue reprimands. And there are stigmas associated with infertility attributed to endometriosis. It may be the woman may be stigmatized, and she may be told that it is generally her fault that they are not able to conceive. And many women may be told that, oh, you will be left over, and now you're not conceiving. We'll marry our son again, and all that. And one important thing that we all fail to focus on is that the economic burden of endometriosis is high, similar to other chronic diseases as diabetes. The cost of medical appointments of endometriosis can add up over time. The cost of medicine. I had recently been prescribing Dynogest to a patient, and who just came back and told me, "Madam, ye bahut mehenga hai treatment." And then I had to, kind of sit back and see if I have to change my methodology a little bit, if I can switch her over to a little more, easier, to the friendlier, to the pocket medication. Additionally, severe endometriosis symptoms can interfere with your ability to balance or maintain a job. If you're thrown out by your employer, then also the financial burden can be huge. And worst part is there is minimal investment made by governments and businesses and medical communities to cure or treat this forgotten kind of disease. So what do we do? How do we handle these expenses? My loud shout to every girl, every woman out there is, please invest in a good insurance early in life, so that when you have to undergo some treatment related to infertility, don't rush for an insurance then, because usually they have a 2-year, 4-year lock-in period before they give you any treatment. For gynecology is like, the insurance company is ready to cough off any payment for it. Look for insurance covers which cover endometriosis. There are now many insurance policies which cover infertility. Look for them, go for them. And there are many who cover the IVF costs also. There are now some insurance companies which are, look for them. Look for support groups. Look for some NGOs which help in women who can deal with them, how to deal with them, who kind of finance these kind of women, or some support groups which do. So what should be our goals? What are we trying to achieve? The goal is early diagnosis and effective intervention. You have to get rid of that 8-year lock-in period, because otherwise that is a doomsday for a woman. And you have to be treating this disease in conjunction with comprehensive, long-term, patient-focused care. You have to know that this is my patient for life almost. And the healthcare delivery models that are most likely to achieve this success incorporate providers beyond gynecologists with a range of complementary skills, including the primary care physicians, psychologists, nurses, pediatricians, adolescent medicine specialists, and others working who can work and communicate together effectively. It's a teamwork. The future plan should be to provide menstrual health and comprehensive sexual education programs in schools. There should be a support government and organization to campaign to promote national and international awareness of endometriosis, educate and train the medical community to ensure early diagnosis and adequate treatment, integrate endometriosis in reproductive, maternal, neonatal, infant, and adolescent health policies and programs, encourage global recommendation for treatment of endometriosis, and coordinate a worldwide epidemiological and socioeconomic study about endometriosis and its consequences. Thank you for a patient learning.
Thank you, ma'am. That was really, really very enriching. Before I jump to the participants who seem to have a lot of questions, and I've seen Dr. Malhotra busily answering online, I have 2 questions myself, and these have come from our focus group discussions that we've been holding. We have had 12 so far, and we will be continuing with our focus group discussions. So in one, we heard a very interesting misconception or a myth that when you have assisted reproduction or IVF, then something is done outside the human body and that mixture is then implanted. And they felt that, this was a very, what can I say, not following the natural process of reproduction, which I think is, and this was coming from a mother-in-law who thought, who knew the concept of test tube baby and felt that something was mixed in a test tube and that mixture was then implanted into the woman's body. So would you like to throw some light on this, either yourself or Dr. Malhotra?
Malhotra, I think it's his forte.
Yeah.
So when the first test tube baby was born, Professor Patrick Steptoe and Robert Edward were almost put into jail, saying that they're doing something which is against God's will.
Yes.
So we have to understand that God willed some diseases also. And when we are fighting infertility, we are fighting that God's will. And that is a tough fight. And sometimes things have to be done outside, which are not possible to be done inside, to give the happiness of motherhood to this couple. So that is what IVF is. It is your own baby. आप ही का अंडा, आप ही के husband का sperm, nobody else's, no mixtures happen, nothing artificial happens. It is your baby that you have to understand. Of course, if the husband cannot produce sperm, if the wife is old, then donor third party. And of course, if the woman does not have a uterus or she's so sick that she cannot carry a baby, surrogacy is of course there. So these are now established. And either mind say, everyone should get rid of it. It is an established treatment which will treat infertility and give joy to the 15% of population which cannot produce children.
Thank you, sir. And ma'am also raised a very important aspect of very small investments from the government and almost no awareness programs. Whereas we know that, and I'm not sure if this could be considered a non-communicable disease, because we know that globally policy around non-communicable diseases has been around since 2011, and there have been a lot of UN programs and resolutions to fight non-communicable diseases. And the ones that usually come under the ambit of non-communicable is diabetes, cancer, COPDs. Now mental health is included. Why is it that women related issues are not part of this NCD agenda? And what can we do to be able to include it? Considering that 1 in 10 women would have this, and this is global statistics, not just India.
Yeah, that was my point exactly. You cannot ignore half of the world's population, and just because other non-communicable diseases affect both men and women equally, then they become a huge programs around it, like diabetes, and you said all of those. And even mental issues, if mental issue is a problem, there is a huge mental burden of endometriosis all over the world. Women suffer like anything because of endometriosis, and it is high time that this one part, I have strong beliefs that endometriosis should be in that list. It should be, in fact, on the top list of non-communicable diseases, chronic diseases that affect women and need redressal.
Thank you, ma'am.
If a woman comes with endometriosis and you write infertility endometriosis, she does not get reimbursement for surgery. They're ridiculous.
Yeah, that is one point we had discussed in the last forum also.
Yeah,
that
but
we have
WHO, fortunately, WHO has now labeled infertility as a disease last year.
And
so it will be covered by insurance.
Insurances, they are now bound to cover it.
Yeah.
People will say ridiculous things like, okay, you are doing this surgery for infertility. Oh, one company actually refused a claim of a, I think, 20-year-old unmarried girl for endometriosis, huge ovarian endometrioma, saying it is infertility. I had to really fight her case. But these are we face these challenges every single day.
Yeah.
And yes, I mean, one big thing that sir has emphasized, and I also emphasize, is that pediatricians or GPs have to know that young girls are not malingering their pains just to skip school. Don't label them. Don't kind of put them in a box that, oh, they need psychological treatment. Please look into endometriosis. This may be one patient, especially I had, was like going for IBS treatment for, I don't know, years together, and she had been in and out of hospitals before I simply put her on an oral contraceptive pill. And she was like, in 3 months, she said, ma'am, it's the first time I have actually sat through all my papers.
So a huge issue of awareness beyond the OBGYN community.
Right. Because we come in a later stage, especially in India, taking a small girl to an OBGYN is a big issue.
Yeah.
Taking hormones is a big issue. My sincere request to all the audience, whosoever are there, is that hormones लेने से कुछ नहीं होता है. मतलब, I'm not saying they are not side effects. Of course, every medicine has side effect, but these hormones can prevent your child from getting a severe disease later on, from getting infertility later on, from missing, and having depression and psychological effects later on.
True. Thank you, ma'am. So we have around 6 or 7 people who would like to ask questions directly. So if Shweta is there, I would like Khushbu to please give her an opportunity to ask her question. Hello, Shweta, please unmute yourself.
Hello, everyone. This is Shweta. Am I audible?
Yes, you are audible. Please go ahead.
My question is, how should couple who are having difficulty conceiving be counseled, given the stigma attached to being childless and also the financial burden of it?
So you like to take that?
So counseling, Dr. Renu has just told you how to counsel them, support groups and all, how to tell them exactly why endometriosis is causing your infertility. And to not to wait too long. See, there are, for infertility, if you're very young, there is expectant treatment. You can wait for 6-8 months, try fertile period, things like that, try mild medicines. Get both of you tested for any additional factor of infertility. And if there are adhesions, if there is endometrioma, if there is severe, get that treated by surgery and try for medically assisted reproduction earlier so that your conception chances improve. Otherwise, expectant treatment is the first thing which we tried if you're very young. And of course, support groups and how to do psychological and mental health. Be positive. Don't think negative. Don't get stressed out. Have a changed lifestyle. Relax. Try to be happy. That is what is required.
Thank you, sir. We have another participant, Sarvani, and she has 2 questions. So, Khushbu, if you could allow Sarvani to ask questions.
Hi. This is Sharwani. You can hear me, right?
Yeah,
Yes,
yeah.
we can. Please go ahead.
Okay. Hi, doctors. As you all know, endometriosis causes severe side effects. Right? I was prescribed some diet actually when I went to gynae. So they were like, they suggested me a few diets. Even though I'm following the same diet, I don't know which foods are causing these severe side effects like extreme fatigue, nausea, bloating. So
No,
actually, this is so difficult to understand which foods are causing these side effects.
No, there you have to first understand that though the foods have been associated with endometriosis, they will not cure or kind of give you endometriosis. Okay, they may aggravate the pain related to endometriosis or they may elevate the pain related to endometriosis, but they are not the per se the cause of your endometriosis. That is the first thing that you have to understand. Okay, and then if you feel that you have endometriosis related pains or any other symptoms, then only food may help. Going off some foods or taking some foods may help, but you will also need additional treatments for it. So if you are told to go off, sometimes you may go off some foods, but the other foods that you're taking may be not suiting your system. So you have to, kind of manage what and all I can eat and what and all. Also, exercise and other things, changing your other lifestyle also helps a lot. But medication should be the mainstay of treatment.
So there's a question which I'd like to take. One anonymous attendee has said, why not adoption versus ART? Well, I was the first one in India as Foxy president to say, have one, adopt one.
Yeah.
And if you have one and adopt one, all the street children of India problem will be solved. Unfortunately, the Indian adoption laws are from 1956 and they have not been revised or changed. And it is so difficult to adopt a child in India that this is not working. And we are, for the information of all who are listening, we all are fighting this a lot. There's another question of audience who seem to be not very happy with the ART and says that we are selling ART, Bhavna Kullar. Yes, your question on endometriosis post-hysterectomy, HRT will work or not. See, if after hysterectomy, the ovaries have been left behind and endometriosis is an estrogen-dependent disease. So that can cause the flare-up even after post-menopause. So how do you, then you have asked, how do you look after the bone health? So to look after bone health after post-menopause, HRT is not the only answer. There are many, many other ways we can look after bone health. And HRT, if it has to be started, if you started very late in menopause, then the role is not there. So the proper treatment for bone health, I think we can take this topic, one whole topic on bone health and managing post-menopausal health and discuss all your points. And please don't be against ART. ART sometimes is the only answer to having babies for endometriotic women.
Also, sir, I want to endometriosis will go. It's not always true. It's not always true, because we may have endometriotic implants beyond our ovaries, and that may still give you trouble even after the hysterectomy, even if your ovaries are removed or even if you go into menopause.
Sir, regarding bone health, I would like to say that in India, hypoproteinemia, meaning low protein and low bone density, is a chronic problem for all women, not just for endometriosis. And it will be a great topic to discuss for women in general, not just endometriosis.
Yes, and the Indian
yeah.
Menopause Society, way back in 2016, Dr. Jaideep started the Club 35. So you have to look after your bones from early age.
Right, sir.
You can't say at 60, I'm osteoporotic. Yes, you're osteoporotic because you didn't look after your bone health when you were 25, 30, 35. So it goes right back. And you just can't say I can take one tablet for bone health at 70 and my bone health will improve.
And then it will become, it's not possible to reverse it.
If it is gone, it is osteoporotic. You did something you didn't, which you should have done at 30s, 35.
So there is one question from one of the audience, Anukruti, and it's a short question, so I'm not calling her. And she says that people have multiple cysts. So how many times can we expect these cysts to recur? And how can we be prepared for that?
See, this is the thing that you have to understand, that endometriosis is a chronic disease. The cysts can recur. There is no how many times. We have had women who have had multiple surgeries during their lifetimes. But I would suggest, and I hope sir agrees with me, is that we try and push the surgery more closer to fertility time when they want to conceive, because that is the best result that they give. And otherwise we try and manage them conservatively unless and until the cysts are very huge, are causing pain per se because of their volume or something. Because otherwise now we have effective treatments which can cure those cysts also, which can at least suppress them till we want the fertility preservation. But when you are going to conceive, that time those drugs we cannot give, because they are all anti-fertility as well as anti-ovulation as well. So my point will be to kind of not operate an adolescent girl or a girl in early 30s where when she's not planning to conceive, but push it towards the time when she is wanting, now ready to conceive, do the surgery then, and then give her a child. Not necessarily by ART, Bhavna. It is not necessary that everybody has to go through ART. And then once she has had her pregnancy, again put her on suppression. Right, sir?
So there are two questions by one of our audience, Tanya. So Tanya, if you would like to ask the question yourself.
So absolutely right on suppression. And someone asked Dynogest, how long can you take? Well, you can now studies are coming that you can take it for more than 1 year, 2 years. There is
7
a study
years,
for 5
sir.
years
The latest
also.
for 7 years, sir.
So 7-year studies also come out. So it can be safely taken for, and then you
Longer
delay the
period.
surgery accordingly. Of course, if the medical treatment is not working, surgery would be required earlier than what you plan.
Tanya, if you could go ahead with your questions.
Am I audible?
Yes, you are.
Sorry, I was like a bad throat right now. So actually, hi everyone. I wanted to ask some questions. One was that the relation between adenomyosis and endometriosis, how are they related? What are the differences and what to look out for? And then there is also some studies have revealed that endometriosis is the precursor, or adenomyosis is a precursor for endometrial cancer. So how likely it is to happen, and what are the things to look out for if our disease is transforming into something else? So basically that was my question.
Okay, basically adenomyosis is endometriosis of the uterine muscle. That is what I can tell you in layman terms. Okay, we all know that endometrial tissue is not where it should be. It can be in ovaries, it can be outside the ovaries, outside the uterus. But when that implant is inside the uterine muscle, so what happens is when you bleed, that part also bleeds, and that is when your muscle starts to swell up and gives you pain, and the uterus starts to enlarge. And this is called adenomyosis. So adenomyosis and endometriosis usually go hand in hand. And most of the people who have endometriosis, most of them will have adenomyosis as well. Though some people may just have adenomyosis and no other symptom of endometriosis outside the ovaries. And adenomyosis per se will give you mostly dysmenorrhea. It will give you a lot of pain during periods, and it can give you one more symptom which we don't see with ovarian endometriosis. It will give you heavy periods, heavy menstruation. So this is what we have to know. Ultrasounds, of course, help. Ultrasound is the easiest mode of diagnosis. And relating to endometrial cancer and adenomyosis, yes, there are studies which have shown relation with adenomyosis. That is also because these patients have what we call endometrial hyperplasias. The endometrial lining becomes thicker. And usually this is around 40 plus age group, where your lining starts becoming thicker and thicker, and your periods start getting a little delayed, but when they come, they are quite heavy. So your adenomyosis gets worsened, as well as your endometrial hyperplasia gets worsened. And these are the cases wherein there are precursors. Then once there is hyperplasia, then there is hyperplasia with atypical cells, and then they can turn into cancers. The easiest advice for women in this age group is, don't label all heavy irregular periods as symptoms of menopause. You know, हमारे यहाँ बहुत normalization होता है उसका भी. अरे period बंद होने वाले होंगे ना मैडम, इसलिए ऐसे हो रहा है. Don't label that. Get your pap smears and endometrial biopsies done whenever the doctors prescribe them. Get your ultrasounds done every year, at least, to see how the endometriosis and lining is progressing. Sir, may you want to add something?
So preventive health is very important for women. For bone health, 35, for all cancer screening after 40 every year, mammography, pap smear, and ultrasound, transvaginal ultrasound, absolutely every year.
There's one question, sir, where they are saying that a lot of women who have chocolate cysts undergo multiple surgeries to remove those cysts. So having multiple surgeries, does it have any effect on fertility? And what precautions should people who have had multiple surgeries take when they are planning for a family?
So as we said when I showed you a surgery, as I said, the surgery should be done by a very experienced endometriosis trained surgeon, above average laparoscopic surgeon.
Most important.
Because it has to be removed completely and without use of lot of burning cautery. So you don't burn the normal ovarian tissue. Obviously, when you're taking out the cyst, some bit of ovarian part is taken out, and the AMH does fall down after surgery, and your ovarian reserve does reduce after surgery. So multiple surgeries are not advocated at all unless it becomes very, very important. First, primary surgery, immediately try to get the patient pregnant. The disease suppresses, keep them on medical treatment as long as possible. Repeat surgeries are not advocated.
So, ma'am raised a very important, and sir, you also raised a very important, point about going to the right expert. And how does a patient understand which expert is right, and how do we then give advice through maybe our patient group as to who is the person who people should be going and seeking, advice from?
So
because
that is a problem in India, because everyone, as soon as they do MD Gynae, they are expert laparoscopic surgeon, they are expert ultrasonologist, they are expert ART people, and they are expert in cancer surgeries. So we need to finally draw a line that I can do this, and if I cannot do this, we have to look into ourselves and say, I cannot do this. My colleague will be doing. So referral, which we don't do, which unfortunately India has to grow large-hearted and bigger still.
Sir, I want to add a point. Besides the referral, I think there is one important point that I want to send a message across. I have seen many of my patients getting operated by general surgeons, especially in the peripheries.
So that is again not advocated at all.
That is,
you can have a general surgeon along with you.
Yeah, at least
You can
see
have it
that.
along with you for tackling bowel
That is fine.
endometriosis,
That is
but
absolutely okay.
not the primary surgery.
Not the primary surgeon. Please see to it that your operating surgeon has the required qualifications, because it's not that they cannot do the surgery. I have nothing against general surgeons, but when it comes to preserving the ovarian tissue, the gynecologists are more paranoid about it. Because we want to save as much as tissue as can, and surgeons may not be that paranoid.
Sensitized. Yeah. So there is one question which I did not really.
Unless of course your husband is a good laparoscopic surgeon and you're guiding him, ye nikalo, wo mat nikalo.
Yeah, that's fine.
So that teamwork is needed.
That teamwork is absolutely acceptable.
There is one question which I didn't really understand, but I'm asking it. Does frequent recurrence of adenomyoma within 6 months concerning? So I interpret that there was a surgery and there was another myoma within 6 months, and is it concerning? So that's the question.
Renu, you can take this. Adenomyoma is the most difficult
Controversy.
Most difficult, because there is no surgery for you. Can never remove it completely from by surgery.
Yeah, I totally agree with sir. I'm not a very big fan of adenomyoma surgery. I'll do it only in extreme cases if I'm pushed. Mostly when it happens that something is diagnosed as a myoma and then it turns out to be an adenomyoma, and I am like stuck, and before I know that there are no planes to it, then I have to do it. But otherwise, repeated surgeries for adenomyoma is a big no. Even a primary surgery for an adenomyoma has a big controversy. But even if you are doing a primary surgery for an adenomyoma done by experts, I have nothing like that. But a second surgery for adenomyoma, no. But if you are asking for a surgery for myoma, that is a simple plain fibroid. Fibroids can recur. You may need 2 surgeries or 3 surgeries or maybe more. I don't know. But usually, even for myomas, more than 2 surgeries are not educated, unless and until it's something really different case scenario or something. But adenomyomas, repeat surgeries, I won't educate at all.
Thank you, ma'am, for that explanation. And there are a lot of questions in the Q&A that have already been answered. So we will make a compendium and share it with our patient group. I just see one more question that has come, I think, in the chat. What is hydrosalpinx?
So hydrosalpinx is collection of fluid in the tubes. Endometriosis will affect the tubes the last.
Okay.
So when it is grade 4, then only. So we are not very worried about hydrosalpinx associated with endometriosis. It will affect the pelvis, it will cause adhesions, then it will affect the ovaries. Last, it comes to the tubes. So hydrosalpinx is a different disease. Usually happens because of infections.
Mostly people will have hematosalpinx, sir. They'll have blood collection and they'll have,
hematosalpinx, blood in the tube
blood
can
in
collect.
the tubes is what is mostly there.
So they have to be surgically corrected, yes.
Then there is another misconception that I heard in terms of the expertise for treating endometriosis. So some of our patients told us that, quote unquote, the general OB-GYNs will not have the experience, but the infertility specialists will have. So people who have infertility specialists outside their clinic will have the experience to treat endometriosis vis-a-vis somebody who is not, treating infertility. And this, I know, is a myth or a misconception. So would you like to throw some light on this?
It's a myth. Every gynecologist is versed with this disease called endometriosis, because the second most commonest disease of the female pelvis. Now, those who are doing a lot of obstetrics, deliveries, supposing you are handling 7-8 deliveries a day, they might not have time enough to counsel and look at you properly. So that maybe a hardcore obstetrician should be left to do only deliveries, and a gynecologist and an infertility. As it is now with the new law, the infertility specialist, that tag will go away, because you have to register, take a separate license for infertility specialist and for ART specialist. 2 licenses separately. Not everyone will be able to practice infertility now with the new law.
Thank you, sir. So many of us are not very well versed with the new law. We just know the controversies that the newspapers threw around the new law, but the benefits of this, many people are not aware. So I see that this session can be followed by a series of sessions on bone health, on surrogacy, on infertility, so many things. So thank you so much, both of you, for your time. I see that we have already crossed 10 minutes over time. There is one question that's popped up. Let me just see. I think this has already been answered. How would you treat diffuse adenomyosis?
Medically. And if you have completed your family and had your babies, then sometimes the uterus have to be removed.
Marina is the first option and hysterectomy is the last.
Marina. You can put in a Marina inside your uterus. We can give you tablets. And if you've completed your surgery and it's not getting cured by medical treatment, then complete removal.
Thank you, sir. Thank you to both the experts today for joining us on a Sunday afternoon. I myself have learned a lot because this is not something that is really discussed very widely. I think it is very exclusive to the OBGYNs. It's not, at least I have not seen in my, interaction with patient groups, etc., where this topic is discussed openly, not only within India, but also globally. So there are very, very strong patient support groups globally, but again, when you go to forums, and for example, WHO recently conducted an informal consultation of people living with non-communicable diseases to collect or gather real-world evidence to influence policy. And we never saw anybody from the women's health issues joining those discussions. So I think your guidance and support for us to increase the footprint of this, women with wings and people suffering from endometriosis would be great. Other conditions like PCOS, PCOD, etc., could also be, lifelong conditions that could join these kind of discussions. So thank you so much, sir and ma'am, for joining us this afternoon for answering the questions.
Dr. Ratna, I just have to make one point before we see that we make people aware of endometriosis. The first and foremost in India would be to get rid of taboos around menstruation.
True.
Let's talk about periods. Let's talk about it. If we talk about if we encourage our daughters to talk about it, our wives, our sisters to talk about it, then only we can take it forward. Then only we will know what they're suffering from.
That is true, ma'am. And there are a few movements already happening, but it is very small. Maybe you should get into, included into the school health program where you already have eye health and,
Absolutely.
So something like that where, and as far as hygiene and sanitation is concerned, some efforts are already there in this, but it should go beyond the sanitation and hygiene part of it and get included into, something that is called women's health and how do we promote. So we have a lot of programs around nutrition and women health, but we don't have anything around menstruation and women's health. So perhaps that is one area that we could look into and then get endometriosis because it is such a common disease and occurs in so many women. So thank you so much, sir and ma'am, once again. And we will write a short report on this and get back to you, and we will seek your further guidance on how to strengthen this group. Thank you so much. Thank you.
Thank you for inviting us.
Thank you,
ma'am. Thank you, sir.
Thank you. Stay safe, everyone, and be healthy.
Thank you, sir. And enjoy your Goa trip, sir.
Thank you.
Thank you, sir.
Thank you.